Well, good morning, everyone, and those of you online and the select valiant people who are here in person in Lecture Theatre 1. And I have to say I've not been very good in the last couple of weeks of turning up in person, but I have been online. It's a really great pleasure to have Professor Fergus Gleeson give the grand round today. Fergus is a regular, gives his annual grand round, which I really enjoy doing, and I can still remember last year's one where we were threatened with AI, and you gave us the real background information, so I'm really looking forward to today. Fergus, many of you will know, Fergus has been here since 1992, having originally trained in Cambridge and then Papworth in London. He's a fellow. He was then a fellow in radiology at UCLA before coming to Oxford in 1992. He's the head of academic radiology. He's the director of the Oxford Imaging Trials Unit and was for, I think, over 10 years divisional director in this hospital, but now is less shackled by managerial responsibilities, but doing even more on the academic side. So, Fergus, it's such a great pleasure to have you here.
Thank you. Thanks, Asham. I'm a backbencher and I'm very old. What I thought I'd do is I've done quite a lot of trials in my time, both single centre and multi-centre. I've even done them across Europe. But what I've never done is large data multi-centre trials. And for those of you that are younger than I am, I thought I might show you, one, what I've been doing, but two, what I've learned about how hard it is, and three, what's coming up along the way that theoretically will make your lives easier, but you'll have other things to face. And then I'm going to show you a few of the bits of, as Churchill said, we are not at the end, but we are at the end of the beginning. So I'll just show you some stuff. So I'm going to talk about DART. I've got some slides I've purloined from Arjun Nair, who is the lead radiologist for NHS England's lung cancer screening programme. And those figures are absolutely awesome. His slides are great, but the figures within them just are amazing. So all of this started, lung cancer screening started, the thought about it started in about 1992, but the first large trial to run and report was the NLST, run by my boss from Los Angeles, that's published in 2011 in the New England Journal. She had a budget of 250 million or so to run this, with others, to run this across America, and they had about 26,000 participants in each arm, and that was strongly positive, with a reduction in mortality of about 20%. From lung cancer, an overall reduction in mortality of 7%. So a strongly positive trial suggesting that lung cancer screening with CT would work. NHS England held off until they got the results of the Nelson trial, which is the slide on your right, published in 2020, to prove that it could be done in a cost-effective fashion. And that was a fantastically run trial, and I'll do show you some details. And that was even more strongly positive. So screening with CT seems to reduce lung cancer mortality. It also reduces all-cause mortality because of coronary artery calcification, etc., detection. So all good news. Did it work in England? There were 5 charitably funded run studies across England, and they had a pooled analysis that showed that actually it was possible to do. They all reduced mortality, weren't of sufficient size singly for it to be of value, but as long as you had a prevalence, and remember that figure, of around about 2%, then screening with CT for lung cancer is of value. So all good, and it was launched. So NHS England did this in what I think is a very sensible fashion. They did a staggered tiered rollout, starting off in the areas of highest disease of poverty and socioeconomic deprivation, higher smoking areas, so that it started, and then moved to lower deprived, higher socioeconomic status. So a very sensible way of doing it. Get out there and do it in the places where lung cancer is going to be highest from the very beginning. And they're going to spend almost £300 million a year on a new programme. So it's got to have a prevalence of about 2%, got to roll it out and got to do it well. So just show you, these are called targeted lung health checks, because not only do they screen you for CT, we've now got one going in Oxford. Does that matter? Okay, so they've now got one in Oxford, they're rolled out, they've got 50 centres, and it's going well in terms of how it's being performed. But you've got to start looking at the figures. So here are the number of people that they have they've invited, and you can see they've invited 1.75 million people. These are smokers and ex-smokers, and they've performed almost 500,000 CT scans. Those are in addition to everybody's day job. But if you look at what's happened, the bottom down here in yellow, the prevalence of disease is less than 2%, because we're now screening people that smoked a bit but haven't smoked for a long time. They're still eligible, so as opposed to how it first started. So the prevalence has gone down, but we're scanning the numbers we should. So how's it doing in terms of detecting cancers? So there are up to 5,000 cancers detected. 75% of them are stage 1 and stage 2, so that's all great news. So we're detecting early stage cancer, but the stuff at the bottom for the CRUK shows you the number of new lung cancers that are presenting each year that are between 45 and 50,000. So in the 3 years or 4 years we've been running, we've detected 5,000 early stage lung cancers, but actually that's only about 10% of the lung cancers that present annually. So it's not going to get rid of lung cancer. And there's a number of reasons for that, such as the age group that we smoke, the people, 50% or so of the people that are eligible aren't actually being scanned, that they may not be performance status 0 and 1, so they may not be suitable for screening. So lung cancer itself is not going to go away in those terms. In terms of socioeconomic deprivation, it's working very well. The numbers of people with lung cancer are, as you'd expect, higher percentage-wise in those that are being screened that are socioeconomic deprived. So that's reverse of other forms of screening, such as breast cancer, etc. So all good, apart from the prevalence, and then this thing. At the moment, we're doing 300,000 CTs a year, but by 2030, we'll be doing 1 million extra CTs a year. So if you think there have been problems with the waiting list before, that's 1 million extra CTs. And that requires, I've highlighted it in red, extra around about 400 consultant radiologists. So anybody that thinks that consultant radiologists are going to be delivering all of this screening in 5 years' time has got to think again, which is where I hope we came in, and I'll show you. So, if we go back to, they launched the programme, what's this got to do with me and us? Well, a group of us wrote the BTS guidelines, published in 2015, and there's the flow chart on the right as to how these nodules should be managed. So, all good, we knew what we were doing. And then Innovate UK and CRUK jointly put out this call for action to see if you could diagnose cancer early. Now, lung cancer screening diagnosed it earlier. We had an AI model that we developed for pulmonary nodules. This is a trial I was running at the time that grant call came out, called IDEAL. So we seemed admirably suited to put in an application for this call. So we told them that we'd use artificial intelligence and we'd improve outcomes in our application. And we said that one of the problems with lung cancer is that all of those up there are T1 lung cancers. But you can see, all the ones with arrows, that they are all clearly not the same lung cancer. They're just not. They behave differently, they look differently, but they're all categorized as the same. So we suggested that if we took all the CT scans, all the outcome data, everything like that, and blood biomarkers, we would be able to develop models to separate them out to try and see if we could improve. The arrows on the right for the graph are the mortality associated with stage 1 lung cancers. So you're not, about 25-30% of people aren't cured by surgery for stage 1 lung cancer, and no one knows why. No one can predict which of those cancers that you resect is going to recur. And clearly, if you can change how they are, if you can predict the mortality from the CT or whatever it is, then actually you can treat them differently. So we said we collect all the, and this is where the problem comes in, all the routinely collected data, so all the clinical data from lung cancer screening, all the CT data, the pathology which we've now digitised and we treat in exactly the same way. Someone shoot that word. And then in a select group, those that go on and had resection, we do take some blood for ctDNA, RNA, proteomics, etc. So what we said we'd do is, using the guidelines that existed, if they gave us the grant, we'd collect the data, we'd use an AI model from Optellum that we're doing the IDEAL trial on, and we'd instigate it. We'd see if you instigated it in the guidelines, you could reduce the number of patients that required more follow-up CTs, and don't forget it'll be 1 million by 2030, and that we'd use blood, this is Roche's blood protein biomarker, that actually we'd reduce the numbers going on to have PET-CT. So we'd take out and improve the selection of patients that were going to be treated and investigated. And that would reduce maybe half the number of people having CT scans. And my ambition in the presentation was to say to them, if you are going to have lung cancer screening and you have an AI model that says that that nodule is likely to be cancer, and you have protein or mRNA or ctDNA that says it's likely to be a lung cancer as well, why would you have a lung biopsy? Lung biopsies are 90 to 95% positive, so they have a false negative rate. But if you've got pre-selection, etc., you can suggest you could be up at 95%. So you'd remove lung biopsies. So that'd remove for Oxford a couple, maybe 5 lung biopsies a week. It would, around the world, it would remove hundreds of thousands of lung biopsies. And there's a mortality of about 1 in 2,000 from lung biopsies. So we figured we'd be able to do that. So we told them that we'd integrate everything that was collected, and we'd get better pre-selection criteria, and we'd be able to better predict outcomes. So they gave us £11.5 million to do this. So quite a lot of money to run this trial, but not 250 million. Then this is just standard. You have to get all your approvals. So you get your HRA, your ethics approval. We also got something called CAG, Confidentiality Advisory Group approval, so that we could, because it's going to be across the country, and because when you're screened maybe on a mobile van. You then go to the hospital where you have your CT scan. Some of the hospitals don't do lung biopsies, so you may go to another hospital to do lung biopsy. You may go to the same hospital. You then have your PET scan, and your PET scan can be in the same hospital, it can be in a mobile van, can be in another hospital, and then you can have your lung resection in the same hospital or a different hospital. Some people send their lung resections, like Swindon might send them to Bristol, Northampton might send it, etc. So what we got approval for was to transfer all of this data over the NHS using patients' NHS numbers. Otherwise, we wouldn't be able to follow them and track them. So we got confidentiality advisory group approval, and we then needed to do all of that for the SCOOT is the blood arm of DART. So all good. And we had fantastic response support from some of the lung health checks. We've got 14 signed up, 4 more wanting to sign up, and we're presenting to NHS England in January to try and get more of the 50 they've already got. So all absolutely great. The pandemic didn't help, because you wouldn't want to do a multi-centre respiratory trial in the middle of a respiratory pandemic, and it really mucked us up and everybody else up, and obviously the poor patients. and everything had to stop, and then we had to restart. But that's fine. And then we got to do all of this. So this is the bit for those of you that are going to run large multi-centre studies involving routinely collected NHS data that becomes problematic for you and has been and is still astoundingly difficult. It should get better. So first of all, you have to transfer the data to Oxford. Now, if you're transferring 3,000 CTs a week, 10,000 CTs a week, and they're all coming in via networks, you get something called data clashes. So they come in, and if you've got data from one lung health check and data from another lung health check, and they arrive CTs at the same time over a VPN, and they arrive actually at the same time, one of them goes after you. And that's great, but the one that goes after you bounces back, and you don't know you've not got their data. So you think you're getting all of the CT scans being transferred over the virtual private network, VPNs, but actually they often, rather like if you open too many windows at the same time, stuff drops out. Then, of course, what came in since we got the grant is you have to run the patient opt-out, and you have to run every single day to see if patients have opted out of their routine collected data. So you have to run that. That didn't exist. And you end up with the most incredibly complicated data flowchart. It doesn't really matter apart from the fact that it's all got to arrive in a way, it all comes in with their NHS numbers, which you've got to anonymise, having done the run-out, opt-out. You've then got to link them all, and it becomes very difficult, is the thing to say. You've got to, then when it comes in, you've got to run your, and this is Jim Davis and Charlie Crichton and the others help run the opt-out, or they do it. It's absolutely fantastic, but it's a problem. But anyway, so you're getting your data in, you're running your opt-out, you're good to go. But you're not good to go, because although everyone says the NHS is marvellous, because everyone's got an NHS number, so you can look at outcomes and things like that and see what the answer is. You can't, because it is the same as having a Mac and a Windows, that actually they're not necessarily compatible. So here you go. On the left-hand side, or your right, is the data that people think about, which is structured, coded data that is all easy to link, because it all comes in, it's all in a standard format, it's all automatically linked, such as ICD-10 codes and prescription codes and radiotherapy codes, etc. So that's all fine. But some of the stuff that we were interested in isn't structured. So a CT scan, you'll have known that a CT scan from one hospital doesn't necessarily come in automatically on your PACS, and it can't be read, etc. So you can't just link them. So, for instance, if you have a PET CT on a Siemens scanner, you can't look at it on a GE workstation. You can't look at it. Okay? They're both PET scans. They both have the same NHS or MRN or RCH or accession number, but they're not viewable on the same platform at all. For your digital pathology, you can have your digital pathology. It can be at 10 magnification or it can be at 80 magnification. So they are completely different as well. The platforms you look at them on are completely different. So you have unstructured data that has NHS numbers that can be linked in terms of their NHS numbers, but you can't actually interrogate them to say, was that an adenocarcinoma? What did the PET CT scan show? Okay, so that's a huge problem. And the pathology reports, which you need, otherwise you're going to have to reread 2,000, 4,000 pathology cases, and obviously I'll show you the data size in a minute, comes in, some of it is on PDFs. Some of it is typed into EPR, and when you run your opt-out, and you run your anonymisation and opt-out, all good, takes the NHS and strips it all out. But if in the report, actually in the body of the report, it says, Mrs. Jones living in 26, etc., then it's no longer anonymised. If the pathologist puts in it, I've referred back to her prior scan, or her prior biopsy, or whatever it is, performed X or Y, and it names it all as it does, in free text, it's not anonymised. So you can say you can link them in terms of NHS number, but you can't use any of the data there at all. So you've got a bunch of unstructured data that you can't use. But I thought, not to worry, at least the CT reports and everything will be easy to look at. That's not correct either, because for lung cancer screening, they're on proformas, and the proformas are then put as DICOM images up as though they're CT scanned, up into packs. They're not on the radiology information systems at all. And all of these are, in effect, just pictures of reports. So you can't interrogate those. And they keep, throughout the report, I've blanked them out, they keep giving you non-anonymisable data. So it gives you the name actually in the picture, gives you their age, date of birth, their accession number, tells you who actually did the report. I mean, so you can link them, but you can't look at any of the data that comes in at all. So that's a problem, particularly if you've got 100,000 of these things coming in. So then in 2022, the government said that we're going to have secure data environments and trusted research environments. And basically that means for all routinely collected data in the NHS, you can only look at it and work on it in an SDE or TRE. You cannot take the data out and look at it anywhere else, ever. So we now have one here run by Kerry Woods and Jim Davies, who's helping us do that. Well, they're doing it, and they're going to help us with access to it with others as well. Blimey. All right, I just put this in here so just to show that this is actively happening. It's mandated. The NIHR came and spoke with the BRC theme leads about it very recently, a couple of weeks ago. It's happening across the country. So all the dark data, which is routinely collected NHS data, has now to be looked at and stored in the SDE and worked on in the trusted research environment. Here is, if you wanted, here's the information to read about it. Okay, so how does that affect DART? Well, these are the pillars of NIHR research that I've listed there, that they list there. Unfortunately, for me, DART fits into 3 of them. So I've really, really, really got to learn how to use the SDE TRE, and I can't just take the stuff, give it to the BDI and say, can we work on it in the Big Data Institute at the university? So I've now got the SDE as an issue, but I've got a lot of help to solve it. I've got unstructured data coming in, and I need help to sort that. And then this was, we're going to collect something called HES and ONS data. HES is health episode statistics that will tell me what patient has had what surgery, what radiotherapy, whether they're still alive, etc. Give me their chemotherapy drugs. So that's all approved. And then this email, and it was approved last year, but we weren't getting any data. And then we got an email, this was in June, saying that they had a problem with their data being corrupted. Not that surprised, because these things do happen. Anyway, so that was why we, despite being approved last year, we still didn't have our data. And then it turns out that they're getting so many requests for data and they're struggling in terms of their manpower, etc., that even after they solved that problem, came out in October saying that actually there are issues with getting people like me and others the data. Fortunately, in last week, or the week before last, I can't remember, we were told that we've now got our data. So where are we? Well, this is how it started. So the NLST, the one from America in 2011, they had 52 or 53 odd thousand participants in their trial, 26,000 having CT. The CT scans they had were 2.5 millimeters. Nelson had 6,000 participants and 200 lung cancers, and their CT scans are state-of-the-art. Obviously, the NLST is old CT data, so not great use. So that's where they got to. So those were the 2 biggest lung cancer screening trials in the world. So how are we doing? Well, we've got 250,000 participants. So just go back. They had that number. We've got 250,000 participants. Post opt-out, we've got still 250,000. We've got 102,000 patients with CTs. That's not just one CT. That figure will be like 250,000 CT scans because there's follow-ups in it as well. We've got 1,500 pathology specimens increasing, and we've got 620 odd blood samples. So we've got, and that's all stored in the SDE and the TRE, ready for everybody that wants to work on lung cancer screening, because that was one of the deals that I made that got us the 11.5 million. So if you are a pathologist AI, if you are a radiologist AI, if you are an epidemiologist, we've got some great people working with us, wanting to look at the different things that affect people that get lung cancer. It's the world's largest data set by a factor of 10. Julia Hipsley-Cox has already published a paper there on the left showing how you can improve lung cancer screening, and we hope to start looking at improving outcome. And so we hope to start making inroads into separating those out over the next 5 or so years, the different lung cancers, to impact upon that. So just a few things that we're starting to look at that are coming up and involve AI, which goes back to my talk last year. So on the left, the targeted lung health check, although I've put an arrow and there's a nodule, that would count as a negative CT screen. The nodule is too small to require follow-up. It obviously went on and became a lung cancer and is FDG avid. So we can go back and we can look at people who've got lung cancer, because we've got all the contemporaneous and their historical CTs. We can go back to see if we can determine which of the small nodules become lung cancer using artificial intelligence. So that'll be an entirely novel field of research, and we can go back to patients that have not got an abnormal lung cancer, an abnormal CT at the beginning, who develop lung cancer, to see if we can determine who of the people with the negative screen actually end up with lung cancer. And there's a group from the Mayo who've invented an algorithm called Sybil that wish to look at our data to see if they can improve their algorithm. That's an open source algorithm, so it could be used by everybody. So you can start to see in terms of how we might improve lung cancer screening. We're also able to look, here is an algorithm that's used in the NHS, in the lung cancer screening, just to detect pulmonary nodules. We can look to see how we can improve this. This algorithm failed to spot a lung cancer on the medial surface of the pleura, but in the mediastinum, and turned out to be a lung cancer. So the algorithms, if you've heard me speak, aren't the answer to everything yet. So we can go back and see how we can improve them. And we've discovered, and this is a thing that is blindingly obvious, but is worthwhile everybody knowing, is that the algorithms have to be updated. You need software updates. So here is a nodule from June of this year, detected by the algorithm and measured with a volume, as you can see there. When you update the algorithm, the nodules it's the same size. You look at it visually, it's the same size, but the algorithm has measured it differently. So software updates don't necessarily improve things. And you've just got to be aware that we didn't know that they were going to be updating their software for the algorithm. They just updated it, and then you've got all the prior volume measurements may change, and that would alter lung cancer screening numbers. So just another example that we've learnt from the large data set. So where have we got to? Well, we're already working with multiple startups and others. So we now, the blood samples are being analysed by Elliptica, who are looking at mass spectrometer proteomics because they think that they can predict who's going to get a lung cancer or other cancers. We're working with Sarah Blagden and RNA Guardian because they think they've got another method of detecting lung cancer with their blood test. We hope to work with In Sitro, who are a company who are going to use the digital pathology to predict outcomes for lung cancer. And John up in the Beatson in Glasgow has developed an algorithm for digital pathology so that he can predict relapse. So, and we're working, as you can see, with a whole bunch of others as well. That's the group involved. I'll just show you this. So that's what Elon Musk said in 2015. There'd be self-driving cars. This is Jeff Hinton, who in 2016 said that you should stop training. He's the father of AI. He won the Nobel Prize this year for his work on AI. And he said in 2016 that there was no need to train any more radiologists because they'd be obsolete in either 5 or 10 years. All their jobs would be taken over by algorithms. And fortunately, neither of them are true. Right. Thank you very much.